Schedule. Okay, ladies and gentlemen, amazing. We are at a meeting in which we're way ahead of schedule. This is great. Yeah, you're stuck with us. Okay, so we are going to do a Q&A. So it'll be probably a little bit less formal. So if you can write it on your sheets of paper, that'd be great, just so I can read them. But if not, you can just go ahead and raise your hand. And we can certainly go. If you have any questions about the questions, please let us know. All right, let's see here. Stenia says, is it safe to be on an SSRI, so a antidepressant, a serotonin-specific reuptake inhibitor, with high-grade nets? So any issues with taking, or even carcinoid for that matter, taking antidepressants? Yeah.
No, there is no problem. So we recommend the patients, if they are on an SSRI, continue with it.
Why did people think it was a problem, Dr. Oberg?
I think they think about increasing the content of serotonin, and that it has been a discussion that serotonin is a growth factor for these tumors. But that has not been demonstrated. That they only increase the serotonin in the brain, not in the body itself.
Does Sweden or other countries accept Americans into their trial?
Yeah, but I must tell you that this virus trial, the first part, the phase 1, I had to do it in Swedish patients. So the first 12 patients has to be in Swedish. But after that, I can open the trial in the 2A phase for foreign patients.
Okay, so some of these questions are a little bit specific for the individuals. I don't want to just talk about individuals because I don't want to talk about you guys too much. But I'll try to generalize them a little bit. So if you had a radioembolization, can you still have PRRT?
Oh yeah. Usually we think it should be at least 12 months between the radioembolization and the start of the PRRT. It can be done.
Do people do PRRT with somatostatin analog therapy?
Yeah. Usually we advise them to stop the somatostatin analog at least 4 to 5 weeks before they get the first dose, the first cycle of PRRT. But then after they have got the dose, let's say 3 or 4 days after the dose, they can take up to the somatostatin analog again.
Is there any role for this new immunotherapy that's coming out, PD-1 inhibitors?
That has to be proven. There is an interesting observation that high-grade tumors with very high proliferation, they express PD-L1 and PD-L2. And these are targets for the PD-1 antibodies. So for me, the next trial with immunotherapy PD-1 antibodies should be in high-grade lung tumors.
I agree. Is there a problem with hormone replacement therapy in head and neck?
That question usually comes up, but that is related to the description that some of the carcinoids, particularly the small intestinal, but also some of typical lung carcinoid, express estrogen receptors. And if you have estrogen receptors and you start to get estrogen replacement, there is a Greek study saying that you get stimulation of the tumor growth. That has not been confirmed, but it is always a matter of discussion, and we don't know for sure if it's dangerous to take.
Any evidence that stress can cause or exacerbate lung neuroendocrine? Depends on how much stress you get, I guess.
I don't have any data on that, but maybe you.
Well, it depends. Like the stress that my wife causes me, or what? I don't know. I would say my comment to this: I don't think there's any direct evidence of that. I think the more important thing is want to do what you're doing now, get educated so that you can be relieved of some emotional stress by understanding and controlling at least the way that you handle and understand your disease. And then second of all, to be as strong as you possibly can, so if you need therapy, you can tolerate and do well from your therapy from that point on. So being as healthy as possible, both spiritually, mentally, and physically, I think are extremely important in any situation, but especially when you're facing something like the physical and you're doing that first step now. You're doing that mentally by improving the way you understand your disease. In Europe, PRT is used early in the disease. However, in the US, PRT is used late. What are your thoughts about that?
Yeah, I must say that it's not uniform in Europe. Some centers, such as Rotterdam and also Bad Berka in Germany, they use it upfront as first-line treatment in small intestinal neuroendocrine tumors. We are a little bit more reluctant. We use it as second or third-line treatment. And the reason is that we don't know the long-term side effects. If you have a patient with a small intestinal neuroendocrine tumor, he can live 20, 25, 30 years from the diagnosis. And if you start immediately to give radioactive treatment, because we see side effects like acute leukemias, we see myelodysplastic syndrome, and we don't know the long-term side effects, not only kidney problems or bone marrow problems. So therefore, I personally is reluctant to give it as first line, second or third line.
Sure, and I totally agree with that. And the other thing too is the problem with PRT is it's only a certain number of bullets, and you can only fire those bullets a certain number of times. Because if you're very fortunate and you can get say 7 or 8 therapies or rounds of PRT, you're lucky. But sometimes you can only get 3 or 4, and that's it. And so, but when it comes to something like a somatostatin analog, you can take that for years and years and years. So you try to milk out as much time as you possibly can. Now the nice thing about the PRT is that it's very well tolerated. It's been demonstrated to be extremely effective, and in general, it's really pretty safe. But at the same time, just because I see a tumor doesn't necessarily mean I want to fire that bullet right now. And progression is different in some people. Maybe one tumor progresses a little bit faster than the rest of them. Or maybe 2 tumors, or maybe 3 tumors, but then the rest of them are very well controlled and somatostatin analog. Well, then maybe rather than damaging someone's bone marrow and potentially taking away one of their therapies, why not do surgery and go cut it out? Because you can get those things out. It's really pretty safe, at least in my experience, pretty safe. Sure, it hurts a little bit, but everyone recovers. The scars heal, and then when the time comes you need something, you can do it. So I always tell people, a lot of you have heard me say this before, the art of neuroendocrine is not knowing what to do, it's really knowing when to do it, right? Because when I see you, I think about you and what I'm going to do for you for the next 5, 10, 15 years. And I know Dr. Oberg has been doing this for so long, he's been seeing things like that. So I need to think about what I'm going to do, so I need to sequence it at the right time and give you the right therapy at the right time when you need it, so you get the biggest bang for your buck. That's kind of how I feel about it. Okay, can lanreotide ever make tumors grow faster?
I have never seen that. Not in patients, not in rats, not in cell cultures.
Yeah. What I can say, I've seen it not work, right? So you can try it and it can progress through it. So that, so
it will not stimulate growth, but it can also be ineffective. So the tumor continues to grow, but it's not stimulating growth.
This is interesting. Someone with nice handwriting. Do you recommend getting the REN test just so it widens the database?
I must say that the REN test is not ready for clinical use. We need to look into it. I think we should continue to collect data, and particularly it's free of charge just now.
Right.
So we get more and more information, but I think it might be the right way to go in the future, because we should know which genes are actually working together, which genes are the driver genes in the tumors. So I think to get that to get to this point, we need to get more information on DNA, RNA level, and so on. So therefore, I think if we collect the data, we learn, and then maybe we can modify it a little bit in the future and use it in the clinic.
And I totally agree with you. Yeah, so if you can get it and you want to get it and you don't mind getting it, then get it. But what I would say is do not interpret the results that come back as being terribly easy. So if you're going to do it for the purposes of helping research, then sure. But if you get a high result, then don't do that. Oh, sorry, let me explain. So the REN test is NET test. It's by a company called REN Diagnostics. The REN Laboratory, thank you, REN Laboratory.
Is it called the NET test?
Yeah, it's called the NET test, which is different from the gallium scan, which is called NET spot, just so you know. But the NET test is basically they draw a little bit of blood and they look at the tiny little bits of circulating DNA inside your blood, and they amplify. No, I'm sorry, circulating RNA in your blood. They amplify it and they test it, and they look at a whole series of different types of, like what if one is up and another one is up, and so there's a whole pattern that they found. And so what they do is they narrow that down to essentially a percentage score. So 80% high and 70% high, and I don't know, between 20 and 70 I think is intermediate.
Yeah, and less than 20%.
Something like that, yeah. It's an evolving test, but that's basically what it is. And I've sent a lot, and I haven't quite figured out how to get together. You can call the company and just say, you're interested in participating in their research. You got to put it that way, so make it a little fuzzy. But then I think they might send it out, or you can come to me. I mean, we do it all the time. So if you want to, at your next visit in Denver, just come by and we'll draw it. But just remember, it's mostly for research. It's not really for your clinical outcome. How accurate is a bone scan for detecting bone calcium? Well, I think it's a traditional, probably.
I think when you started to use gallium PET scans now from July this year, I don't think you will continue with any bone scans, technetium bone scans, because it's a waste of money.
Yeah, I totally agree. There is a very, very fancy bone scan called a sodium chloride PET scan, and if you had bone mets, it might not be unreasonable, but for somebody who's seen me, I've stuck in that MR machine for a long time. We do what's called a bone skeletal survey with MR, and that actually works pretty well. So in combination with gallium scan, where we can do kind of a pan scan of your body, assuming the gallium works for you, plus a bone MRI, I think that's probably the best way to go to look at your bone mets. But don't forget, a lot of people actually live with bone mets for a very long time. It doesn't cause them a lot of problems. So it depends on what the clinical kind of need and indication are. When the new drug to control serotonin is approved, it's called telotrestat by the FDA. Will insurance cover it for lung noise? And the same question for PRRT. So the question is, basically, when these new therapies come out, since a lot of them are tested in gut, will it be approved for lung? I can answer that question, I think. The answer is probably maybe. And that's really all purely dependent upon probably your insurance. So some insurance companies won't cover anything. Some insurance companies will only cover small things, and some insurance companies force me and Pam to fight them all day long in order to get things done. So it's not so easy. These new drugs are not going to be cheap. I guarantee you that. And so, we will hopefully, as a neuroendocrine kind of center, they'll be a little bit more lenient with us, and they'll listen to what we have to say. We can write kind of form letters for you all. But I don't know for sure. Will it be covered by insurance? Yes, they will be covered by insurance because it will be approved by Medicare and be approved by the FDA. But will they always give it to you? Maybe not, because all those drugs were tested in digestive neuroendocrine. So we'll see.
If you are in Europe or in Sweden, it's covered.
Yeah, but then you'd learn Swedish. That's the only problem. It's better than Finnish, let me tell you. That's a much harder language. That's true. I will say that. So when I lived in Sweden back in 2010, it was me, my wife, my 2-year-old, and my 4-month-old. Michelle has met my children. And so there's no question my 2-year-old learned more Swedish than I did. And the great thing about it was when I was there, I would go to say like radiology conference or something, and they'd say, "Oh, Eric's here. We're speaking English today." I was like, "Oh my god, that was great." And they would conduct the whole thing in English. And then more importantly, every time you went to the McDonald's, everyone spoke English, and so you could always order just the right food. Okay, this is interesting. When will RMCC be designated as a center of excellence so insurance covers travel? That's really interesting. I've been here now for a whole year now, 12 months, hooray. And the problem is RMCC is not a brand name, right? So I know a lot of you have done this. You go to the brand names like MD Anderson and Memorial and Mayo or whatever, and not always been so delighted with the expertise in neuroendocrine. I mean, they're great hospitals, they're great centers, I don't question that, but maybe specifically in neuroendocrine, or just the care or whatever, you didn't connect with your doctor. And so what we're trying to do, it's a project, but what we're trying to do, now that I've been there for a year, we're collecting a lot more information and data so we can apply for actually the European Neuroendocrine Tumor Society. They have a certification process for Center of Excellence. So the University of Iowa just got one because they got a big government research grant. So I don't know how they got designated, but maybe it's self-designated as a Center of Excellence. But the ENETS program has a very, very clear guideline. You have to have so many patients, you have to have so many surgeries, you have to do this and this and this and this. You have to have tumor boards, it's multidisciplinary. So I believe in those guidelines because it's more clinically related. It's more about clinical center of excellence for caring for you. So we're working on that. So hopefully once we get that, I can help cover your travel, I guess. I didn't know you would cover travel.
I can say that until now we have just done it in Europe. We have 35 centers all over Europe now that are certified.
Yeah, the Australians, I think.
And now we are going to Australia because they have requested to get certification, and so we go to Melbourne and Sydney to look at that.
That's great.
And then we have also got a request actually from Toronto.
Oh, good.
And also from Stanford.
Yeah, that's great. So there's definitely a lot of interest. So, and one of the projects for the Healing Net Foundation is to try to get this process going. So get involved if you can, help support the foundation. It's something that they're very keenly interested in. Okay, if the primary has been removed successfully surgically, do you ever do a second surgery? So that depends. So if you have lung surgery, certainly, hopefully we'd like to get those things out. If you have kind of quiet lymph nodes, we may not necessarily go back after them. If they misbehave, you may go back after them. But doing a repeat lung surgery is a lot harder than doing a repeat belly surgery, just so you know. Now, if you operate in a different body cavity, then it's not unreasonable. So for example, say someone has had their lung surgery, but they did a bunch of liver mets. Well, I can go into their liver, and it's essentially, for me anyway, it's essentially a new operation. So there's no problem. But I can go into the belly multiple times. Going into the chest is more difficult and there's more risk to it, but going into the belly is a lot easier. And what size is the tumor when you recommend biopsy? Do you biopsy second tumor? Sure, yeah, biopsies we can do all the time. For me personally, the biopsy is not as interesting, because usually I know what it is and I watch it. For me, the much more interesting test is the test of time. I would much rather see how your tumors behave over time, because it gives me a better sense of their biology and their kind of personality. Now, if someone, for example, like Cindy Lovelace, I did biopsy her again because she had breast cancer. So I didn't know if her disease was breast cancer or was neuroendocrine. I assumed it was neuroendocrine because it was the metastatic behavior. But for her, a second biopsy is actually really very, very important. So, if for example, you had a very strong history of breast cancer and you had a lesion in your breast, and you had like a lung neuroendocrine tumor, then I might biopsy that to make sure you don't have breast cancer. That's the kind of thing. For me, what do you think?
I agree with you.
Okay, we talked about autoimmunity. Did we talk about the gallium scan and non-functional tumors? Did we talk about that?
No.
Okay, all right. So the question is the gallium scan equally diagnostic in patients with non-functional as well as functional tumors?
Yes.
I like that. That's a Donald Trump answer. Strong.
I can tell it because we started to use it in non-functioning tumors, and then we went on with functioning. So I can say yes.
Yeah, because the relationship with the somatostatin receptor is not necessarily the functional or non-functional. That's kind of the key to it. However, if your tumor doesn't express somatostatin receptor, then the test will tell me that your tumors don't express somatostatin receptor. So in my hands, about half of the lung patients don't express somatostatin receptor. And the reason I know that is because I stuck them with the gallium scan, and it came back negative. It was a biopsy-proven neuroendocrine tumor. So, and we've also done stains for it too. So that's how I know. Yes, ma'am. Because I saw them on MR. Yeah, so for example, you see them on, this is why I'm such a belts and suspenders kind of guy. I mean, you know, there's a reason why I lie in these machines for so long. It's because I've seen the tests be wrong, right? I've seen too many CAT scans be wrong. I mean, we've seen many CAT scans be wrong just because of the way that they shoot the contrast and timing in the CT scan. So for example, it's very common for people to say, oh, I had a CAT scan, 8 years ago because I had a kidney stone, right? You may have heard, you may have had the story. And can you look at my CAT scan to take a look at it? I say, that CAT scan's no good because there's no contrast in it. Because they'll think, well, I was tumor-free 8 years ago. But in fact, the CAT scan is not meaningful. So, but however, the MRI may show something that the gallium may not. So now, with our experience in gallium, I know what the weaknesses of gallium are. So you've got to kind of cross-check these things and cross your T's and dot your I's in order to really know what's going on. In some cases, I think some people don't want to know what's going on. But for me, kind of as a med expert, I think it's really important. Because first of all, I can talk you off the ledge, right? Because I understand this. And more importantly, I won't be caught by surprise. This is the thing. I hate being caught by surprise. Yeah, Randy. Speak up, Randy. Make sure everyone can hear you.
No, actually, we are not using PRT in patients with negative gallium PET scan because we know there is a very nice study done by Professor Richard Baum in Bad Berka looking at biopsies from the tumor, staining with specific antibodies for receptor 2 and 5, and so then comparing the standard uptake values on gallium PET, and he could correlate almost the number of receptors by this. So if you have a negative gallium PET, it's not of any value. It's just side effects to give you PR.
Right, so it's more like a companion diagnostic. Think of it that way. Go ahead, Lynn. Roughly. Well, this is the whole point. This is why we want to have... No. I can image you. I can image you with CT. I can image you with MR if I know. Right.
But yeah, there are a lot of other receptors if you start to look for GRP receptors and some other GRP CPR receptors. So, but there is no developed either imaging and or treatment procedures for these receptors. But I mean, you shouldn't just hang up on receptors because you can go for targeted treatments, you can go for a combination with targeted treatments and chemo. So there are a lot of other things to do, not just blindly look at PRT as a problem solver. And as Eric says, there is a difference also between atypical and typical. There are more typical lung carcinomas that are positive on gallium than the atypical ones.
Right. So, and that's why you want to see a neuroendocrine expert, because you want to make sure your whole toolbox is full and used. And so that's the thing. And sometimes, like, surgery is still, a good, debulking is still a good therapy for you guys. Sometimes it's a good diagnostic. So, these things, this is why, just because you get a CAT scan that shows something doesn't mean that that's the end story, right? There's always something to be done. And the other question, too, is what is the leading edge of disease? So I think real long and hard, but what's going to kill you, right? So if anyone of you guys read my blog a couple weeks ago, someone asked a very kind of like deep, pointed question, like, why do we die? Or why do people with neuroendocrine die? And everyone dies, right? But why do people with neuroendocrine die? So I explained that. And so my goal is to always improve your quality of life as much as I can. And, somatostatin analogs and targeted therapies, PRT, whatever, surgery, whatever it takes. But then the other thing is what's threatening you. Let's say you had a tumor in your intestine and it was blocking your intestine and you died from a blockage. I can fix that. You remove the tumor, the blockage goes away. Let's say you have a blockage in one of your airways, right? Well, Dr. Kobater can go out there and fry it. Even if we can't cure you of it, we can certainly improve your status. So, the what we call the leading edge of disease, the one that's most life-threatening, is the thing that we have to think about. And we should address it. And, sometimes, look, PRT does not make, your blockages disappear. You know what makes it disappear? A pair of scissors and a knife.
No, a surgeon is talking.
Go ahead, Bob. What did you say? Oh, sorry. Yeah. Yes. Now the sequencing is really very, very important, and you see that because you see mostly American. I'll answer you, but because you see patients in the U.S. So again, this becomes a problem. So when the PRT becomes more available, so this is one of the reasons why I keep harping about you're seeing a neuroendocrine specialist, because we know more about the things that are available and how one can hurt the other. So for example, if I pound you with chemotherapy, and your bone marrow turns to mush on chemo, and then I send you to Dr. Oberg to save me essentially in my treatment, and your bone marrow is shredded up, he's going to say,
"Oh, I'm not doing PRT then."
Right, exactly. Or for example, if someone has had multiple operations and multiple, let's say, not effective operations, and then I have to go back in there, right? Then it's more dangerous. Or so Dr. Nutting's here, for example, if someone did some kind of embolization into the liver, didn't do a great job for it, and then all the arteries are clogged up and he can't get his radioactive therapy into you, you're gonna struggle. So there is truth to that. So that's why I always say, for example, I will see a patient, they are doing pretty well, we've debulked them, they have a little bit of stuff, it's progressing or whatever, their Sando or the lanreotide isn't quite cutting it. I say, look, I think you should probably get some PRT, and we've shipped the patients over to Sweden before. I mean, in fact, one of the first people who ever get a gallium scan in the United States, she was not an operative candidate anymore, and coming from me, that means a lot. And I said, just go to Sweden, and she's like 4 years later, she's still cooking along, just completely asymptomatic. And it was because she got good PRT therapy in Uppsala. So it's all about knowing what to do.
I must point out, it's very important now when after the NETTER-1 study, PRT will be available in the US, that it's not spread out to all different types of institutions that are not familiar with it and doesn't know how to modify doses and things like that when they see some negative effects on bone marrow, on kidney function and things like that. So I think it should be concentrated to some centers in the country, maybe one in each state.
Right, yeah, exactly. And so gallium is another good example. A gallium scan is great, right? But a gallium scan doesn't mean anything except for the person who interprets it and helps you figure out what to do with it, right? It's not necessarily the test that means anything. It's how it helps you in your ability to care for it. So you can have a gallium scan, and someone can make a terrible decision based on it. They could say, oh, well, you should have the head of your pancreas removed because I see some signal there. And they'll come see me and say, oh, no, that's what happens with gallium. Sometimes you get these things that aren't exactly right. So we need to check this and this and this. I've seen it before. And it's only because I've been doing this for, 6 years now that we understand it.
Just a comment on that. I got lawsuit from Singapore because there was a surgeon that had just started with gallium, and he saw some uptake in the head of the pancreas. And we know that there are some PP cells that pick up this normal. So this is not a tumor. But he said immediately, this is a tumor. He made a Whipple's procedure, the guy, and the guy ran into so complicated problems and diabetes mellitus, and he was almost dying, so therefore it became a lawsuit.
Right, and that's the thing. It's ultimately it's still the person working with you, thinking about you, that will always be the most important thing. You know, these tools and these tests are great. Don't get me wrong, I love them more than anyone does, but it's only because I can take better care of you. Does that make sense? No. We just tossed you in the gallium scanner. Right. Well, they're all pretty good. So the question was, there are 3 flavors of gallium scan. Remember, just to clarify, so the gallium, we call it by shorthand the gallium scan, but it's a gallium-68. Okay. The gallium-68 is a light bulb. The DOTA, this is DOTA on there, that's the cage that holds the light bulb. And then the tate part of it is Octria tate, or Octria knock, or Octria top, essentially. So that's the one that does the honing in. If you want, go to my Facebook site. There's Chris Nashville's put a bunch of videos of. Oh, actually, you guys did a video. I did it with NCAN a while ago, explaining gallium. So take a look if you want to understand it. But the question is, what are the differences in these 3? They're pretty close, but I suspect what will happen is eventually, but they're still under trial. So now that NetSpot gallium dotatate is approved, it is the exact same molecule as lutetium dotatate, or PRT. So it'll be easier to get, and it's more directly related. It's a better companion diagnostic. So, but I think if your DOTA knock scan was okay, I would still give you a PRT. Certainly, if your DOTA tox scan was okay, I'd certainly give you a PRT.
We have tested all 3 types of molecules, and I must say there is no difference between tate and top. But the knock is binding some other receptors as well, receptor 3 and more on receptor 5 as well. So, but I don't think there is a major difference.
Right. It's close enough. It's close enough. Yeah, Randy. Yeah, it's a different test. So MIBG is kind of like the cells eat the MIBG, and so it goes into the cell. It's kind of absorbing the pathway, and it lights up. So it's a slightly different thing. With the dotatate, it binds to the receptor on the surface of it, and then it binds and goes inside. And so it's just it's a different biology. So what it's called functional imaging. So you take a light bulb, you hook it to some kind of molecule, and you see how the cell biologically reacts to it. And so we're just lucky neuroendocrine tumors have a whole bunch of this somatostatin receptor. And so we've exploited that kind of to the max that you possibly can. We have a cold drug against it. We have an imaging agent against it. And now you have a therapeutic radioactive agent against it. So that's kind of how it is.
My personal feeling for MIBG is that this is going down. And the reason is that it's unspecific. It's difficult to get high doses into the tumor. We have tried it for carcinoma tumor, classical midgut carcinoma tumor. And the other thing is you have to isolate the patient for a week in your ward.
A paraganglioma,
Paraganglioma, there might be a role, but not the usual.
Right, the usual neuroendocrine we're talking about, especially the lung. Any genetics that you guys are working on besides the immune one?
We have some genetics on small intestinal neuroendocrine tumors because we have LN families with inherited forms of small intestinal tumors. So that is something we are working on just now. We have no other genetic program just for lung medicine.
Any factors associated with predicting the organ of origin, Am I asking this question right? What factors associated with neuroendocrine tumors are indicators of origin?
It can be TTF1 or anything.
Yeah, okay, I'm not sure I'm asking that question right, but there are some tests that can give you a sense of where the tumor comes from. So the problem with the lung is pretty complicated because the lung can either be a primary site or it can be a metastatic site. So sometimes you don't always know, you can't always figure out. It's usually pretty obvious because you find the other primary site and just assume it went to the lung. But we saw a case that it looked like it started the lung and then went to the pancreas. Yeah, so really pretty unusual. Yeah, right? A case, I won't say who. Anyway, but it's just interesting. And so there are certain tests. In fact, there's a company called Biotheranostics that has a test that helps to predict where the tissue comes from. And then there's, but most of it is just kind of figuring out by either by staining or by Biotheranostics or just by good clinical workup. So maybe we'll take one more. There are a lot here, but I think a lot of them were addressed. So a couple people asked about sleep apnea. Sleep apnea is a very complicated issue. The question here specifically is after surgery, can you have sleep apnea, and can sleep apnea be related to these things? I think the answer is probably not, because sleep apnea is complicated, and there are lots of people with sleep apnea who don't necessarily have neuroendocrine cancer or neuroendocrine tumors. But I do think that it's something that is underdiagnosed and needs to be addressed. So I certainly have people who say have even small intestinal neuroendocrine tumors who have sleep apnea, so it's not necessarily related to the lungs. What it is, unfortunately, frequently related to is like obesity, right? Issues like that, kind of the more mundane, common things. So as much as we like to blame everything on the carcinoids and neuroendocrine, not everything can. Is wheezing a long-term problem? Like,
I mean, wheezing is not a big problem for most lung heads, but if you have it, it can be a long-term problem. And of course, you can always try somatostatin to see if you can improve it.
Right, there you go. That was the next question. Should it be treated? Certainly, if you have wheezing, it's symptomatic. If you can't live with it, then you should definitely see your pulmonologist to consider the possibility of getting just good old-fashioned medical therapy for it. Don't forget, inhalers and anti-inflammatories, and anti-asthma drugs still may have some benefit. So definitely consider that. But we also have discovered that there is an endocrine form of asthma.
Yeah.
You talk about that.
I think it's correlated to production of so-called tachykines that are small hormones, neurokinin A, neuropeptide K, and substance P, and they regulate the blood flow in the bronchus, and also they constrict the bronchus sometimes, and they can cause this problem with wheezing. And if you give somatostatin analogs, you reduce the levels of these tachykines.
All right, so let's do one more, and this is a good segue to Dr. Nutting. But liver mets. If one has multiple liver mets, but they are small and stable, should they be removed or left alone until they start to grow? That's actually an interesting question. So if you have a few, so again, it's the timing of it. It's not when you to do it. It's not what to do. It's when to do it. So, so if you have small lesions and they're behaved and they're well controlled and either on therapy or off therapy, I think it's perfectly reasonable to leave them in and watch them. If they cause you problems, then you should remove them. So even a very small tumor can secrete a ton of hormone and can really torture you. And so getting those removed safely, of course, is a very good therapy. If you're doing fine, and I have many patients, and again, I'm a surgeon, right? So I know how to do this. But I have a lot of patients who have tumors in their liver, and they're perfectly stable, and so we just let them sit for a while. I make them promise that they'll never leave me, because then the moment they start to misbehave, it's a problem. And so the next question is, what causes them to become unstable? Neuroendocrine, and you can tell me what you think, Shel, is a very heterogeneous disease. Not only is it different from you to you to you to you, but it's different from each tumor within each individual person. So some of the tumors may be mixed. They may be more sensitive to somatostatin analog, and some may be more active. And we've had tumors. I have this superstar pathologist back at Vanderbilt I used to work with named Chen Zhenxi, And I made her cut into every tumor I cut out. She hated me for this. No, she loved me. But, of course she loved me, right. But she found that in some cases they were all the same, very uniform. They were all like 1 or 2%. And then she found that some of them were, some would be 1 or 2%. So in small bowel. Some were very low grade, 1 or 2%. And then some of them would be 30%. And then even within the individual tumor, you had these hot spots, like Dr. Ryan talked about, some hot spots in which this spot was very, very active, and that whole area was very quiet. So it's extremely heterogeneous. What makes it trigger, I don't really know. But at least I like to think that we have a lot of different modalities to treat them if they start to misbehave. They're like children, right? Sometimes your children are great, and you got that one that's just mischievous.
I can also tell you they really made a study, looked at the genetic deletions in pancreatic nets. So we took two non-functioning pancreatic nets. We divided them into 4 pieces. And all 4 pieces have different genetic profiles. So heterogeneity is something we had to work with.
Yeah, it is life, right? I mean, for me, the analogy, I'm like, it's a little bit like trying to cure poverty or trying to eliminate crime. It's not easy. And if you can keep it contained, you can keep it controlled, and society still functions, in other words, your health is maintained, your quality of life is maintained, then we've done something good. I've learned to tolerate terrible looking scans. But the most important thing is I don't treat scans. I treat you. And that's always the bottom line, and that's the thing you should always take home. Okay, good. So